Welcome to today's video on anemia of chronic kidney disease. I will discuss diagnostic criteria, management strategies, and the latest treatment guidelines to help you better understand how to address this common yet complex condition. Let's get started. So how do we diagnose anemia in CKD? The diagnosis is likely if all of the following criteria are met. Low hemoglobin. Typically, we see a drop in hemoglobin levels as a primary indicator. CKD, this is confirmed by an eGFR less than 60, or evidence of kidney damage such as proteinuria. No clear alternative cause. It's important to rule out other potential causes like iron deficiency, B12 or folate deficiency, or active blood loss. Low or normal reticulocyte count. Reticulocytes, which are immature red blood cells, are often low or normal in CKD-related anemia. Iron stores. While not always the case, iron stores are often low in these patients, but this alone is not diagnostic. Once you've established that a patient might have anemia due to CKD, the next step is setting treatment goals. According to the 2025 KDIGO guidelines, treatment should be considered if hemoglobin falls below 10 grams per deciliter, but the exact approach depends on individual factors such as symptoms, rate of decline, and other comorbidities. Hemoglobin Target Range. The target for hemoglobin in CKD patients should be between 10 and 11.5 grams per deciliter. It's crucial not to raise it higher than that to avoid complications like stroke, hypertension, and thrombosis. Warning on ESAs. Erythropoiesis-stimulating agents should not be used to intentionally raise hemoglobin above 13 grams per deciliter due to these risks. Now let's talk about iron therapy and how to manage this aspect of CKD anemia. When treating anemia of CKD, iron is often a key player. The primary goal is to ensure that iron levels are adequate so that ESAs can be effective. For non-dialysis CKD, ferritin should be greater than 100 nanograms per milliliter. For dialysis patients, ferritin should exceed 200 nanograms per milliliter. Transferrin saturation. This should be greater than 20% to ensure sufficient iron is available. These are the classic minimum threshold goals for iron stores. If you have any patients on ESA therapy, this is the zone you want to aim for. But when should you start or stop iron therapy? Let's break it down. The KDIGO guidelines give us specific thresholds for initiating or withholding iron therapy. Initiate iron therapy in dialysis patients if ferritin less than or equal to 500 nanograms per milliliter and TSAT less than or equal to 30%. Withhold iron if ferritin greater than or equal to 700 nanograms per milliliter or TSAT greater than or equal to 40%. It's crucial to understand these aren't treatment goals, but thresholds for when to start or stop iron. Some confusion arises because people often mistake these as target values. When the hemoglobin level falls below 10 grams per deciliter and after ensuring adequate iron stores, erythropoiesis-stimulating agents can be used. These medications help stimulate red blood cell production in the bone marrow. For both IV and subcutaneous routes, 50 to 100 international units per kilogram 3 times a week. Check hemoglobin every 2 to 4 weeks. If hemoglobin increases by less than 1 gram per deciliter in 4 weeks, increase the dose by 25%. If hemoglobin increases by more than 1 gram per deciliter in 2 weeks or exceeds 11 grams per deciliter, reduce the dose by 25% or more, or stop altogether. Now, what do we do when a patient doesn't respond to traditional therapies or has high inflammation? There's emerging treatment on the horizon. In cases where anemia is ESA resistant or there's high inflammation, a new class of medications called HIF-PH inhibitors is showing promise. One such drug, roxadustat, stimulates the body's own erythropoietin and improves iron metabolism. This is a promising addition to the treatment arsenal. Finally, let's talk about interpreting ferritin levels and the nuances in managing iron in CKD patients. Ferritin between 200 to 500 nanograms per milliliter and TSAT greater than 20 to 30%. This indicates adequate iron stores. No routine IV iron needed unless hemoglobin drops or ESA resistance occurs. Ferritin 200 to 500 nanograms per milliliter, but TSAT low. This suggests functional iron deficiency, where iron is present but not available. In such cases, IV iron may be administered cautiously, especially if the patient is on ESA and anemia is not improving. Ferritin climbing towards 500 with stable hemoglobin. If ferritin rises above 500, hold off on iron supplementation to avoid crossing the 700 nanograms per milliliter threshold, which can increase oxidative stress and infection risk. To summarize, the goal in anemia of CKD is to carefully manage iron levels and hemoglobin targets to avoid complications. We aim for a hemoglobin range of 10 to 11.5 grams per deciliter, keep iron reserves adequate, and monitor closely for any signs of ESA resistance. New treatments, such as HIF-PH inhibitors, are available for patients who don't respond well to traditional therapies. Remember, anemia management in CKD requires a careful balance, and following the KDIGO guidelines can help you achieve the best outcomes for your patients. Thanks for watching. If you found this video helpful, please like, share, and subscribe for more updates on kidney disease management. If you have any questions, leave them in the comments below, and I'll be happy to answer them. See you next time.